right, thank you everybody. I'm going to be talking about occupational exposure history. I think this is a very challenging topic for several reasons. One, I think obviously it's a limited amount of time that you have with the patient, but more so than that, I think a lot of us, particularly with some of the, unless you have some exposure, not to use that word, imagining exactly what your patient is actually describing in terms of occupational environmental settings can be very challenging, and they're so immersed in their exposures that they have a hard time actually describing it. But I think it has important health consequences both for the patient, and I think as somebody with an occupational medicine background, I think the second piece I think about is the public health and really preventing disease in other patients. Because I know for patients who have chronic diseases, the exposures are often long gone, and so you're wondering, what am I going to do with that information? Although there may be medical legal consequences, reimbursement consequences, things like that that actually could be relevant. But I think from a public health perspective, actually exploring these things tend to be important as well. So these are my disclosures. So what are we talking about when we talk about exposure-related interstitial lung diseases? So traditionally, I think we think a lot about them as the pneumoconioses. In a lot of my referrals, there'll be a simple question about asbestosis. But begs the question, if asbestosis can cause a UIP pattern, are we really sure that no other chronic exposures can? There's been a lot of interest in hypersensitivity pneumonitis, acute, and actually specifically chronic, because it may be very challenging to differentiate that from idiopathic pulmonary fibrosis and other idiopathic interstitial pneumonias. So frankly, all of the idiopathic interstitial pneumonias, including NSIP, including even DIP, have been associated with occupational environmental exposures as well. In terms of clinical history is the key component to this to really, so there's no, while we may talk about serum precipitins and biopsies and things like that, clinical history is really the most important piece to this. And we can think about exposure-related lung diseases in different ways. We can think about acute versus chronic, so your acute hypersensitivity pneumonitis versus a chronic. You can think about them as fibrotic, non-fibrotic, and reversible versus irreversible, and stable versus progressive. And understanding chronic exposures that may be latent may have an impact on how you handle these things, but I try to make the categories something that I can explain to patients in terms of why I'm looking for exposures. And then of course there's the whole quandary of there's certain ILD patterns, like a chronic hypersensitivity pneumonitis may suggest an exposure, and you really have to do a hunt for the exposure. So again, just going back to this, and this of course, this cartoon is a bunch of people, it's too late for them. However, the reality is if they're still getting exposed, it's possible. We do know that removing the exposure may actually improve outcomes for those patients, not only in the acute setting where you presume there's some reversibility, but also in the chronic setting. And then of course there's preventing disease in asymptomatic patients and future potential exposed populations. And so this is the world of ILDs, and you can see here, we spend a lot of time on that green box over there in terms of exposures. So what are the diseases, occupational interstitial lung diseases, that we're actually talking about? And this is one way of looking at it. I think traditionally we're very comfortable about thinking about the pneumoconioses, silica, coal mining, coal workers pneumoconiosis, asbestosis. And then there's the whole area of hypersensitivity pneumonitis. You have other granulomatous diseases, so for example, beryllium disease, chronic beryllium disease is indistinguishable from sarcoidosis. And then there's the diffuse interstitial fibrosis, so acute inhalational injuries, and I would also argue any kind of progressive interstitial fibrosis as well. So there are really several categories, and these are examples of your hypersensitivity pneumonitis. Probably most commonly I'm seeing in my practice, which is not up there actually, is our bird owners, because most of the patients that I see are domestic. But agricultural exposures, humidifier lung, anytime there's water, there can be microbial overgrowth, and patients can develop a hypersensitivity pneumonitis. And we'll talk about some of these in some of the other slides. But what about idiopathic pulmonary fibrosis? Well, I would argue that it's not just asbestosis. There have been several epidemiologic studies, and as you can imagine, most of these studies are really based on case control. They're based on questionnaires. There's not a lot of people going into an environment and doing actual air sampling, et cetera. But based on some of the questionnaire data, there's several themes that emerge. Metal dust comes up consistently in many of these studies. Wood dust, which I didn't highlight, doesn't always reach significance, but has been reported in a lot of patients. And smoking actually is a strong risk factor also for developing diseases. And then what about the difference between idiopathic pulmonary fibrosis or chronic hypersensitivity pneumonitis? Well, we'll hear about later that there's certain radiographic and pathologic features that can distinguish chronic HP from IPF. And we spend a lot of time in our clinic actually evaluating patients. And in fact, in a study from 2013, we noted that 20 out of 46 IPF patients, when the diagnosis was explored further, they either had serum precipitins, they'd had a bronchoalveolar lavage at some point where it showed a significant amount of lymphocytosis. They had, in many settings, specific inhalation challenge testing where somebody's exposed in a control environment to see if they have a change in spirometry, although that's something mainly done in research settings. And then, of course, pathology as well, where they actually had chronic HP and not IPF. And then, of course, further complicating things, chronic HP, although we think that there are features that differentiate chronic HP from IPF, it is possible that patients present with a complete UIP pattern even though they've had a chronic exposure. So, and I know we'll talk about this a little later in terms of radiographic exposures, but for the chronic HP patients, you can see that there are a number of histopathologic patterns in addition to what we think about in terms of granulomas, airway center disease. You can also get a UIP-like pattern in these patients as well. And then, of course, there's the group of patients where you don't find an antigen. So this is somebody with a very classic-looking CAT scan where there's mosaic attenuation, there's nodules, it's upper mid-lung zone predominant, and there are exposures, but we haven't identified them. We do know that exposure identification, even in these chronic patients, is associated with an improved outcome. And so patients where you're able to find the exposure and remove it can actually improve survival. So moving on to a few cases. So this is a 55-year-old gentleman who worked as a pipe fitter, and he presented in 2004 with a dry cough. And as typical of many of the patients, he had been treated for upper respiratory infection, and already he had significant pulmonary impairment at that time. And he presented with a CAT scan, which looks pretty consistent with an acute HP pattern, with lots of central lobular nodules there, and then went on to have a tissue biopsy where you can see some poorly formed granulomas and lymphocytic infiltrate. So in terms of going into his occupational history, and I think when somebody tells you that they're a machine operator or somebody tells you that I work in a factory, as opposed to getting your eyes glazed over like, I don't know what that means, I think what I usually start with is I say, okay, what's the name of your company? What does your company make? How big is the company? What's your job title? How long have you worked there? And I do this for every single job. Now, when you're looking for acute exposures, you're looking for a temporal relationship with symptoms, but for the chronic exposures, you're really going all the way back, down job by job, including, in some cases in Connecticut, so including, for example, we have a lot of patients who were in the Navy who had asbestos exposure. So I go all the way to military exposures. I ask them about what materials they use. I asked them, particularly for the patients where there was acute symptoms, were there any process changes? Were there any new chemicals introduced? And legally, anybody who's working, any worker has access to safety data sheets from the employer. So if they have a new material that they're working with, they have the right to go ask the employer to give them information on whatever's available. And then, of course, exploring the temporal associations between symptoms and work. And then you want to look at an exposure estimate, and really don't underutilize the obvious questions. Was it really dusty? Did you see dust in the air? Was it misty? When you coughed, was your sputum, did it look black? Did you look like it was a dirty environment, suggesting that the engineering controls were really poor? And what kind of personal protective equipment did you have? And then in terms of engineering controls, was there local exhaust ventilation? Or, you'll see patients where there's not a lot of local exhaust ventilation who have more symptoms during the winter because the doors are closed or the window's not open, particularly, for example, in the auto body shop workers that I've seen in some of our clinics. And then, of course, what kind of process is it? So processes that are wet, you tend not to have airborne particles that get reintroduced into the air, so I do ask about those questions as well. And then what can also be very helpful is, are any of your coworkers symptomatic? And I think this is a key question when you're exploring new types of exposures. So for this particular patient, going back to the case, he'd been employed there for 3 years. Symptoms had started. They had started using a new metalworking fluid. There had been a recent process change. And asking the patient, there had been several coworkers who also had symptoms. And this actually went on to the Department of Public Health at Michigan, and they further identified 4 total cases of hypersensitivity pneumonitis. And they went in there and they looked to see that it was individuals working around this central 50,000-gallon metalworking fluid container. And further investigation revealed on culturing it that there was non-tuberculosis mycobacteria, which has been reported in terms of metalworking fluids. And so the intervention included initially trying to add more additives to try to kill the non-tuberculosis mycobacteria, improving local exhaust controls, and when that didn't actually work, eventually they actually substituted it. So metalworking fluids are very common, have been reported frequently in terms of causing hypersensitivity pneumonitis, and it's generally the ones that have water in it that may be associated with HP. So some of the key points from this: several workers were from the same plant, recent process change, and exposure identification to figure out what it actually was required somebody going in there and sampling. And then ultimately local exhaust controls, which didn't work initially, and then finally changing the exposure. So this is another case of a 35-year-old male who developed respiratory symptoms resolving 12 months after work cessation. And then a second 28-year-old man presented with similar complaints, and both worked in a textile plant in Rhode Island. And then further inquiry at the company level, and this happened later on after it went to medical care, was that there were 5 ILD cases in an Ontario plant for the same company. And these were the clinical features of what was presented. So the CAT scan showing peripheral reticular markings, ground glass, micronodularity, honeycombing. And on the ones that actually ended up having a biopsy, it was bronchiole-centric, so anything airway makes you think of an inhalational exposure, lymphocytic predominant infiltrate. And NIOSH, which is the National Institution for Occupational Safety and Health, went in and actually partnered with both industry workers to really go in and try to figure out what was going on, because they didn't know what the causative exposure was. And they did an investigation of everybody in the plant, and they further identified more individuals. And they noted that there was variation in outcomes. Some patients progressed, many improved without the exposure. And simply just walking through and taking random air samples, they eventually found that there was basically these fibers, or this flock that was produced. It was a nylon flock plant. And that cutting these filaments were producing these, and it was a very dusty area without local exhaust control. And that the individuals who worked in those areas where there was a lot of that airborne dust, went on to develop disease. So what they ended up doing is they introduced a lot of controls. They had patients wear respirators. They made sure that the cutters that were being used were actually sharp, so you weren't producing these jagged edges on the fibers, which seemed to invoke more toxicity, and they improved ventilation. And so this was an example of nylon flock worker's lung, and we don't think about it, but I mean, this is something this flocking industry, in terms of putting these fibers on surfaces, we see all the time on upholstery and other materials. So in any case, new working group guidelines came out. This really made a tremendous difference in improving control. So the key points in this was a rare disease presentation in a young person. This is a 40-some-year-old. There was a presence of disease in other coworkers, and they really had to go in to identify the causative antigens. And the importance of environmental controls as opposed to substitution was very key in this situation. Okay, so this is another case, trying to talk fast. 69-year-old male former smoker referred from primary care with the insidious onset of shortness of breath and a cough. And so this is sort of your typical pipe fitter for 30 years, and that's not such a great example of a pleural plaque, but this is an individual who had asbestosis. And so generally asbestosis, I think we all know this, long latency period, at least 20 to 30 years. The exposures have typically gone down in the 1970s and after OSHA put out a standard in the 80s, and their exposure limits in terms of what your peak exposure levels can be over an 8-hour time-weighted average during the day, or also how much short-term peak exposures you can have. And per OSHA, individuals who are exposed to asbestos have to all be in a medical surveillance program involving chest x-rays, questionnaires, and spirometry. And this is an example of the safety data sheet for asbestos that I was describing. And again, remember, all the workers in any plant really legally have a right to actually get appropriate training for respirators, get the information, the safety data sheets for interpretation. And this is just to kind of go back to asbestosis. We really are only seeing this in individuals who are older, perhaps new products, and frankly, most of the individuals who are doing asbestos abatement really are covered nicely in personal protective equipment, so you don't see it. And the diagnosis of asbestosis really involves clinical history is key. You have to have plausible exposure, so even if you don't have a pleural plaque or you're not isolating asbestos on tissue, if you have a plausible exposure history, that is sufficient to make the diagnosis. If you happen to get tissue, you're not going to see asbestos bodies unless you actually ask for iron stain, and oftentimes the asbestos fibers have actually been absorbed by the body, so you may not see any actually. And then electron microscopy, which I've only done sort of in more research or other settings, will actually be able to tell you what is the component of the iron. So the iron stain will coat anything that is a foreign material, but it doesn't tell you that it's an asbestos. If you really want to know what is there, you want to go on for electron microscopy. That's typically not available, so what I end up asking for often with slides that come over is I will ask for iron stains if my pathologist can do it. So just in terms of chronic diseases, exposures can be very remote. There can be a very long latency period, recall bias, and historical exposures for some of these things. So my patients who are in construction or working with asbestos, typically in the 70s and 80s, the exposures were higher. This is the last case. So 60-year-old woman who presents with a chronic insidious dyspnea on exertion and non-productive cough. She has upper lung zone predominant disease. She has evidence of air trapping. And I'm not sure, I don't know if the radiologist agrees with me on the ground glass, but so in any case, further history, she took care of a property where there was a poultry farm with a chicken coop. And actually, this particular patient didn't tell me how many birds that she was exposed to, and then my PA saw the home that she took care of on the lifestyles of the rich and famous, and it was this house like filled with birds, so I think she was underplaying it because she couldn't find another job. And she actually denied symptoms related to work. I don't think I'm going to be able to open this, but what this is, and I'm happy to share this with people, is we talked about a standardized questionnaire, really asking patients about their history, what their job titles were, how long they worked there, and asking for some key exposures related to hypersensitivity, pneumonitis, metals, et cetera. So what else for hypersensitivity pneumonitis have individuals used? Well, there's serum precipitins. And this is a paper from looking at patients with bird fancier's lung. And unfortunately, it has limited utility because you can see that here, patients who were control and didn't have ILD, 87% of them still had serum precipitins. There is some cross-reactivity. I know sometimes we're searching for the exact serum precipitin to find on your EPIC order set and you can't find it. But there is cross-reactivity with some of the birds. And so unfortunately, standardization is lacking. It may not correlate with disease. It may just be a marker with exposure, and it could be a false negative because you might not have actually gotten the right antigen. And then finally, specific inhalation challenge testing. This is really not something that we do commonly in our clinic, but this is literally taking a diluted antigen extraction, putting somebody in a chamber, and then 20 minutes later monitoring their spirometry, their temperature, their O2 saturation, and looking to see if they have evidence of a reaction. Clearly, we're not doing this in patients with severe disease, and it's limited to specialized centers and mostly for research purposes. According to this study, at least, by Munoz, there seemed to be higher utility with avian and fungal exposures than it did with some other exposures, such as isocyanates. But this may be something as our interest grows in HP that we might be thinking about. We certainly have to have a safe place to do it. So, hold on a second. I'm going to actually skip. So, I know some of this is going to be alluded to as well. I think my slides are not working. So there's a significant interest in looking at hypersensitivity pneumonitis and chronic HP. And I think, we alluded to, and I'm hoping that some others will be alluding to some of the differences between hypersensitivity pneumonitis and chronic and idiopathic pulmonary fibrosis, which is one of our most challenging issues. Some of the features that can be helpful, for example, on bronchoalveolar lavage, here in the middle is a lymphocytosis of greater than 25 to 30% versus patients with a lymphocytosis less than 20%. On pathology, typically hypersensitivity pneumonitis patients, you'll see evidence of granulomas and lymphocytic infiltrates. And then in terms of chronic HP, mostly you don't actually see those granulomas or bronchocentricity, which suggests an airway, an inhalational exposure. And so there's certainly an interest in actually developing some clinical criteria for us to actually diagnose and treat patients with hypersensitivity pneumonitis. And so ending a very long presentation, so occupational exposures are associated with multiple patterns of interstitial lung disease. Careful occupational history is key and may be the first clue to exposure and can have important public health implications. Supplemental testing such as serum precipitins or specific inhalation challenge testing may be useful in selected settings but has numerous limitations. And finally, distinguishing chronic HP from IPF may have important treatment implications.